He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome back. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. Today, we are joined by Dr. Stewart Lonky, who actually has some work in a field that I am vaguely familiar with, and I hope we get to talk about it. But Phil, I'm just going to sit back and kind of listen, and then when I hear something where I can go, I'm going to jump in. So take it away.
Yeah, I'll be curious to hear which aspect of Dr. Lonky's work you're particularly curious about. I'm excited to have this conversation. Dr. Lonky is the author of the book called Outsmarting Obesity. And, I thought it would be great to have him on, discuss about what he's learned about obesity along the way. He has a long and very prolific career looking at obesity, among other things. And so excited to kind of hear what he's learned and what he can share with us. Before we kind of jump into the book and all of that, why don't you let our audience learn a little bit about you, give a little bit of your background, and maybe talk about how you became interested in obesity and ultimately led to you writing the book.
Sure. I'm actually a transplanted East Coaster. So I went to undergraduate school in upstate New York at a small university, St. Lawrence University, got a good liberal arts education, and went down to med school in New York and became an internal medicine intern, moved to St. Louis to finish my residency, and on to San Diego, where I became a National Institutes of Health pulmonary biochemistry fellow. So I did my fellowship at UC San Diego in pulmonary medicine and critical care medicine, but my lab work was always at the biochemical level on lung injury. So I'm a chemist by heart. I love biochemistry, and I loved looking at things from a biochemical aspect, and that was the area of my research while I was at UC San Diego. And they gave me a lot of latitude, which I liked, and decided that rather than stay in the academic realm, I'd go into practice. And I went into practice in Los Angeles in pulmonary, internal medicine, pulmonary critical care. So you can imagine I spent a lot of my time in the intensive care unit and taking care of people on and off ventilators and so on. And over the years, as my practice grew in the office, I realized how many of my patients were large. Extra large, and it was getting worse. And it wasn't really until about 12, 13 years ago when I had a nurse practitioner in my practice, and she was wonderful, and she always peppered me with questions, and we kept putting people on diets to try and get their pulmonary function better. I mean, when you get very large, you get sleep apnea, those are people that stop breathing in the middle of the night. They get complications, which I won't go into right now. But also they're more difficult to manage because if they get a pulmonary infection, they're limited. Their lungs become more restricted. They have less volume. You have less lung. And we'd get people on diets and they'd gain their weight right back after they'd go off the diet, even if they went on what they thought was a modified diet afterwards. And Tess is her name, and she kept asking me why, and I said, So I did what I do best. That is, I delved into the literature and started talking to researchers and following everything. And the more I learned, the more curious I got. And I became convinced within the last 5 years that we've got it all wrong. That the concept of calories in and calories out, it's a nice concept. Here's what I tell my patients, and I tell everybody. I don't think that I've met a patient that can't lose weight. I think patients can lose weight. You can put them on a diet, you can restrict their calories, you can inject them with Ozempic. 20 years ago, 10 years ago, we were using fen-phen. But whatever you want to use, you can lose weight. The problem is they can't keep it off. The data show that 2/3 of the patients gain all their weight back in 2 years. 95% gain all their weight back in 5 years. That's what got me interested in writing this book, because as I learned, I realized we think we're smart, but we're not. We think that the diet companies are here to help us lose weight, but they're really here to help us go on this roller coaster. They're businesses. What I learned is not something you hear a lot about. You don't hear people talking about what I wrote about in the book. And I come to the conclusions because nobody wants you to know it, because that would put a kind of an end to the diet industry. I looked at data. Let's just look at this. When John Kennedy was inaugurated in 1961, the obesity rate in the United States was 13%, and he was very upset. He thought it was way too high. The obesity rate for kids was just under 5%. So since that time to the present time, more than $3 trillion have been spent by the American public on diet foods, diet plans, diet drugs. And what did we get for this? Oh, we got 43% obesity, 13% to 43%. Pretty good. Not. The kids went from less than 5% to just under 21%. We're doing something wrong. It's all wrong. The whole approach is wrong. It's not that, I'm not a nihilist. For exercise is fantastic. And Chris Talley, who's an elite sports nutritionist, dietitian, contributed to my book, and he's a very good friend. And we talk about exercise all the time. It's great. But that's not going to keep the weight off, because there's a basic problem. And as I begin to peel the onion back, I start to realize what that problem is. And so when I discovered that, I felt I've got to write a book, because maybe nobody will read it. But with things going on the way they are right now in this country, with maybe a push, maybe finally a push to understanding that we've got to get healthier. We've got to get healthier. I see kids with sleep apnea. Okay, Jack, Phil, I see kids with sleep apnea. The diabetic rate in kids, off the wall. We can't sustain this. There's no way we could sustain this problem. And it's just become way too expensive medically. And hopefully people will listen to the message. It'll get across there, and we will be able to make people more aware of why. Because if they get smart, you can actually outsmart it. And the plan, I wasn't going to write a book that was a doomsday message. I was going to write a book that was able to help people. So once you understood it, you know how to fight it.
Let's do this. Let's define, first of all, what is a doctor? What is somebody who's actually in clinical practice like you define as obesity?
Good question.
What are you looking at when you say this is obesity?
We're stuck with BMI, okay? And BMI is what we've used for 50 years or more. And we define a BMI of 30 to 35 as mild obesity. 35 to 40, moderate. Over 40, some people call it severe, other people call it, morbid obesity. I have patients with BMIs of 50, 55.
Okay.
So BMI is the definition. If you're over 30, you're defined as being obese. Is that fair? It's probably not. But it's the easiest thing to do because it's based on height and weight. As my wife always reminds me, she was never overweight. She was just under tall.
Under tall.
If she could just be a few inches taller, she's not overweight. But she always made jokes about it. But That's the problem with BMI. My grandson is 16 and a half, is a hockey player, very muscular.
Yeah.
He could probably calculate out to be obese if he wanted to, when he's at the right weight. Certainly, Arnold Schwarzenegger is not obese, was never
Yeah.
obese, but he would have been calculated as obese. But yeah, it's height and weight. To me, my definition is the one thing that's common in all forms of obesity is underlying inflammatory markers.
We'll get to the details first, but I'm going to assume that people who are at the far end of the scale, they know they've got a problem. And those folks are going to opt in to listen. All right, I've got a problem. Dr. Lonky, what do I do? We're not going to have any trouble with those folks thinking they need to listen. What I want to make sure we do is would address those folks who may think, I'm a little fluffy, but eh. And so this is where Phil comes into this. Aside from a highly unfocused, inaccurate measurement like body mass index, what are some of the other things that people who might not really be aware that they're on the cusp of obesity-induced health problems, even if they may not perceive themselves as obese?
And
yeah,
yeah,
go ahead.
I would just before you answer, the other thing I would throw in there, you mentioned, okay, if you have a lot of muscle, maybe your BMI is higher than 30 and you're not, but we really shouldn't be thinking of you as obese. I also want to point out there are some people who have a BMI of under 30, but we still should be thinking of them as obese. And that will kind of probably be covered in how you answer Jack's question as well.
Yeah, I think the basic underlying theme here is you raise an interesting point. The biggest problem population is those people between, let's say, BMIs of 28, 29, 30, up to about 35 or 36. Many of them think they're just a little overweight. There was an interesting study of people with BMIs all over 35. The majority of them did not consider themselves to be obese. The majority, it's 2/3. So when questioned, they said, yes, I know what obesity is, but I'm not obese. I think the markers that you have to look for is when you go to the doctor and they say you're not diabetic, but look at the complications. You have three major complications of obesity. Number one is diabetes. Number two is heart disease, coronary artery disease to be exact. And number three is cancer. Certainly breast, colon, certain other cancers, prostate, all of these cancers are related to obesity. Those are inarguable facts. But I think that the key thing for people to see is, where is your hemoglobin A1C? I'm just a little pre-diabetic. It's nothing. My mother was diabetic and I have pre-diabetes. That's a sign. Look at the triglycerides. Look at the cholesterol, particularly whether your HDLs are high enough to balance out the LDLs. How high are your low-density lipoprotein in your cholesterol? So those are the helpful hints that I can give people, because those are the early stages of the complications of diabetes. And if you're already there, it means complications of obesity. And the complications of obesity come about, unfortunately, slowly. I often say, there was the pandemic of SARS-CoV-2. And God knows, as a pulmonologist, I saw my fill. But the fact is that this is a catastrophe in slow motion, obesity. Yeah. It happens slowly. But those are the things I ask people to be aware of. We could look at skin fold thickness, but people don't measure their skin folds at home.
I'm thinking of folks. I want of the thousands of people who are going to hear this show, I want people to be able to self-evaluate, to ask themselves, I wonder if this little fluffiness is maybe more than just fluffy. I'm asking you, what are some other things people can do? I know the lab tests are great. Is the only way to Is the only way to get a more objective view of it is get labs done?
If you're wearing clothes that continually need to be let out, you have a problem. Okay? That's to me, listen, I'm not immune to this too. I used to weigh 200, almost 230 pounds. That was 30 years ago, 35 years ago.
Hmm.
I couldn't wear my clothes. I mean, you put on a pair of pants, or for a woman, a dress, a skirt. My wife always says the reason why women buy shoes is because you put on a pair of shoes and you never look fat in the shoes. You don't. You put on a dress, you say, I look fat in that dress. So they don't buy it.
I've literally, in my entire life, I've never heard that before. I
Yes.
love that.
Yeah, you don't
Oh,
look fat in shoes. You always look good in shoes.
these shoes
So
don't make me fat.
they don't make me look fat. But, the fact is, I think what we want to do is, these are the hints. I'm wearing the same size. My tailor looks at me now, because I don't have time to go shopping and stuff. Every once in a while, if I need a suit or something, I have a tailor here. It's about the same price as a suit in the store. And he says, all my people, they change, but you don't change. Those are the things that you should be looking at. You may shrink a little bit, and we all do, but I'm talking about, your waist, whether or not there's extra fat that you notice around in your chest area, particularly in your chest area, and the upper abdomen area, the high abdomen. Everybody has low abdominal fat. That happens naturally unless you're really well toned. So I look at people and say, look at yourself in the mirror. I'm not 25 anymore. I said, no, you're not. But the fact is, you should be really not expanding out sideways. That's not something you should be doing. So those are the helpful hints besides laboratory data.
Yeah.
So what is it about the obesity that causes the trouble, right? You mentioned the consequences: diabetes, heart disease, cancer, these things that are associated, that happen because you're obese. What actually is the obesity doing in or to our bodies, right, that is causing these consequences?
Obesity leads to malfunction of your fat cell.
Well, obesity leads to malfunction of your fat cell?
Yes.
It's a downstream effect. It's not okay, you go expand on this here.
I think most people don't understand that your fat cell is an endocrine organ. Most people think fat is just, oh, that's ugly. Ooh. When you opened up the abdomen, when you were beginning your surgery residency, and when I was a medical student and the operating room, and I saw that omentum and I saw that omental fat, and so I was, ugh, that's fat. But fat is an endocrine organ. We know that. It secretes a number of different hormones, one of which you've probably heard of, leptin. Leptin is secreted by your fat cells. When your fat cells, it's a signal for you to stop eating, that you're full. There's aponectin, which dictates insulin secretion. So your fat cells are responsive to how metabolism is happening and how you're burning your glucose, and it fights against it. It can result in insulin resistance.
Right.
So all of these things happen because fat cells don't function. Now, when fat cells get bigger, that is, they hypertrophy, you can either get more fat cells, which is one of the things that happens early in your life, and we'll talk about that. But your fat cells can get bigger. When the fat cell gets bigger, it stops functioning well because it becomes hypoxic. That means it doesn't get enough oxygen.
As a fat cell that gets hypertrophic loses its innate capacity to process oxygen effectively.
The oxygen doesn't diffuse all the way into the cell. Interesting work, done 20 years
I
ago.
realize this is real nerdy kind of stuff, but this
It's
is
very
super
nerdy, but
fascinating to me.
suffice it to say that oxygen will only diffuse a certain distance into a fat cell. And it's like any other cell in your
Oh,
body, it needs oxygen. So when
right.
you get fat cell hypoxemia or hypoxia, low oxygen levels, it kind of screws up the signaling. Oh, should
Sure, that
I
makes
make
sense.
leptin? Should I not make leptin? I call it sick fat. And it's sick because not only is it not getting enough oxygen, but step number two becomes obesity. The more fat you have, the more storage area you have for the real culprit in the game here, which is environmental toxins.
Oh,
Most environmental toxins are not water soluble. They are water insoluble. They get into your body and you cannot urinate them out without the help of your liver. We're talking about organophosphates. I'm talking about nonstick cookware with PFAS, with perfluorochemicals. I'm talking about flame retardants that are everywhere in our environment. I'm talking about plastics and all of the things that go into plastics. All of these chemicals that are organic chemicals that if I drew a sample of blood on you, and they've done this in many countries, and everybody has about, a couple of hundred toxins in their blood. If you're willing to pay the money to test for it, yes. The average newborn baby in the placental blood has over 200 toxic chemicals in its blood. They don't
now
have functional livers.
let
So
me ask
these
you this
toxic
question.
chemicals, let me just finish that off.
Okay.
They are soluble in fat. They're not soluble in water. The liver has to break them down and convert them into something that you can urinate. Because once it's in your body, the only way out is urine. That's it. Okay, if it never got into your body, it would come out in your excrement. But once it gets in, once it gets absorbed through your skin, through your lungs, and mostly through your GI tract, it's there and it gets plunked into your fat cell. So the average fat cell is sitting there with all of these different dioxin and PFOA and so on and so forth. And they're waiting for a telephone call from the liver saying, all right, I'm ready for you. Come on down here. I'll break you down. But every day you're exposed to more. So it's a losing battle. Now the question becomes, what are these toxins doing? And what we've learned is that they are causing what are known as epigenetic changes.
Sure.
Now, what is an epigenetic? For your listeners and viewers, an epigenetic change is something that happens on the surface of the gene. So you can't change your genes. Your genes are your genes. Genes with a G, I'm talking about. Genes with a J, you can change. Okay. But genes with a G, the genetics, you're born with. That's your genetics. But we learn a lot from twin studies where one twin is obese and one twin is thin. How could that be? So it's not genetic, it's epigenetic. And epigenetics means the changes that occur on the surface of the gene. So there are chemical groups, mostly methyl groups, a carbon with 3 hydrogens, CH3. Well, there's no tests here. It's just CH3. It's a molecule that attaches to the surface of the gene, and it either turns the gene on or turns the gene off. That we know. That's been known for many years, probably 30, 40 years now. Do we talk a lot about it? Outside of cancer, not much. But these epigenetic changes are what dictate, for example, you have one gene that, for example, in a developing fetus and in you and me, we have a gene that dictates whether a developing cell, a cell that's developing in the fetus, is either going to become a muscle cell or a fat cell. That's the PARR gamma 2 gene. But just one of many. About 140 genes are involved in whether we become obese or not. And depending on if they're turned on or turned off will depend on what happens. When do they get turned on or turned off? It starts in utero, and it goes through childhood, and it goes through the rest of our lives. But here's the good news. You can't change your genes, but you can change your epigenome.
Sure.
You can modify that. And we're beginning to learn more and more ways behaviorally, and a lot of it is behavior, and some of it is cleaning out some of these toxins. So it's a combination of not being involved with toxins, and the other side is, getting them out of the body. What really got me involved with this level was certain inescapable facts. It's not just humans are getting fatter. Animals are getting fatter. You could say, the animals in the wild, marmosets, monkeys, mice are home pets. They even have a pet obesity society now. They're all getting fatter. They are all getting fatter. And you could say that's because, they eat the processed foods, and some of that may be true, but how do you explain that in a laboratory animal? How do you explain that, Dr. Oveda, in an animal, a rat or a mouse that's on a very controlled diet? We used rats and mice in obesity studies. There are OB mice that are obesity mice. We have, a number of different species that we raise to do obesity studies. And the fact is, they are getting fatter, even though they're brought up on a diet that is totally controlled. But here's the other one. Newborns are getting fatter. The average weight of a newborn is up 25% in the last 30 years. And it isn't because they're going to 7-Eleven and getting Twinkies. It just isn't. Not because they don't work out enough. Okay, that isn't the problem. So if you go on a diet and you lose weight, and you can, when you go off that diet, your epigenetics are fighting you. You can't outsmart that. You can't beat that.
I want to ask you this question. You said, remember, I'm not medical, I'm not scientific. I'm kind of the avatar for the average listener here. You said that our fat cells get bigger, and as they get bigger, the oxygen doesn't infuse into them as far as it typically would in a normal fat cell. And that is the mechanism by which the fat cell begins to dysfunction. And then, and this is the part where I'm not clear, does the environmental toxins, is it the fact that the fat cells are bigger make the effect of the environmental toxins more intense? Is it the environmental toxins that are making the fat cells bigger? Is it or if we didn't have these dysfunctioning fat cells, would we be better able to process the environmental toxins? I realize I just threw a lot at you, but those questions are stirring, bubbling around in here.
Okay, let's put it this way. We are, as a population, every one of us, a toxic soup, except starting in the womb. Fat cells are already occupied by these organic chemicals that are waiting to be broken down. So those fat cells that have a high concentration are already malfunctioning.
Okay.
The way that, hypertrophy of a fat cell, we can make more fat cells, and in some instances that happens. And that may be better, but I don't think anyone's looked at whether those animal models or humans that make more fat cells instead of bigger fat cells are better off, because they're all toxic. But the oxygen supply is better if your fat cell is smaller. If you have more of them,
which would imply it probably processes everything else better.
But then it implies that you have to have enough blood supply bringing the oxygen to all those extra fat cells you've just made. So in either instance, you get all of these different changes in the fat cell. It doesn't work as well. Now you're also battling with the epigenetic changes that you have inherited, and these epigenetic changes are heritable. They go on for at least 3 generations that we know of. For example, in famine-stricken countries, we have followed women who were pregnant during a famine. Their children are normal, but the next generations are obese. And they're obese, yes. Why? Because epigenetic changes have happened to make you store fat. So we're set for a famine. I mean, the United States is ready for the next famine. I mean, we'll see.
As gallows humor there.
I mean, but that's really what happens. It's the same in animal models. So the first generation may be normal, but they're passing these epigenetic changes on, which are telling metabolism to don't make muscle, make fat. You never know when a famine's coming.
Yeah.
Okay? And
Right.
that little attachment hangs on for at least 2 or 3 generations. What kinds of things does it affect? Epigenetics is all over. You look at the obstetric and gynecologic and reproductive health literature. When I went to medical school in the 60s, everybody got pregnant. Everybody, we were worried. They developed birth control pills. We never had assisted reproduction. Today, due to these epigenetic changes that have happened on sperm cells primarily, guys, yeah, it's our fault. Our sperm cells they swim up to an egg and say hi and swim on by because the epigenetics have made us develop an industry called assisted reproduction. Who ever heard of that? So you think about all the things, breast cancer, for example, related to obesity because we're getting bigger. It was 1 in 20 women were going to get breast cancer when I was in med school. Now it's what, 1 in 7, 1 in 8 are going to get some form of breast cancer. It's just changing. So epigenetics becomes something that's pretty important, but the nice part about it is since much of it is induced by the environment and environmental toxins, we have 2 choices, the way I look at it. There are 85,000 chemicals currently approved for use in the United States. And all of this is in the book. And it's as simply as I'm putting it right now is how it's written. It's not written in any esoteric, but it's all referenced. So for those people who like to go deeper, you can go to the literature. All these references are there. They were double checked by the editors. And it's a really good book in that respect. It's over 300-400 references. But the fact is, we have 85,000 chemicals that are commercially available in the United States. Cleared by FDA? Oh, no. Cleared by FTC, Federal Trade Commission. Oh, yes. FDA doesn't clear it.
Oh, okay. Yeah.
Yeah, see, so if you have an air freshener, you want to plug it in the wall, and it makes your room smell nice, the FTC says, go ahead and market it because it's not going to burn the house down. But the chemicals that come out of there, they fall on the floor. You have a new baby, babies crawl around, they crawl in. What do they do with their hands? Put them in their mouths.
Yeah.
So this is how we're getting fatter. Our conveniences are 85,000 chemicals deep. And we're not going to give up those conveniences. And believe me, we can lobby to get rid of many of those chemicals. We will lose. It is smarter to figure out how to not let those chemicals get in our bodies. And that's the approach that the book takes. That's what the AIPE program is. Accept, identify, prevent, eliminate. And that's what it's all about. Accept the fact that we're toxic, identify the toxins in your world, in your life, in your home, and in your behaviors. Because behavioral changes also can modify your epigenetics, usually in a positive way. So that means doing things on a continual basis alters epigenetics. It's been shown that people who are weekend warriors have no epigenetic changes whatsoever. But if you exercise on a regular basis, 5 days a week, 4 days a week, but on a regular schedule, your epigenetics favorably change. Don't ask me why. I don't know, but they do. Learning to have strategies to limit your caloric intake. Go to the supermarket and read the contents, the ingredients on any product. My wife will not let anything in the house that has any chemical name on it. This is the way we have to modify ourselves. We have to begin to be aware of the fact that these processed foods that are going to stay on the shelves for 20 years, and ladies, your lipstick that is going to still look fresh after you've used it for a month, they have parabens in it, and that's why they look fresh. You're absorbing them through your skin and so on and so forth. They're obesogens. These chemicals are referred to as obesogens, and your listeners and viewers can look up that word and start reading about obesogens and the various chemicals that have been proven to result in obesity. They cause these epigenetic changes. But the whole idea is to identify, then prevent them from getting in. It's actually not that hard. There are a number of different ways. There are ways that we can prevent getting a giant dose on a daily basis. The toughest part is eliminate.
Are there things that are there common daily use types of products that are obesogens that you've been able to identify?
Most makeups, all of those nonstick cookware that you have that have a chemical coating on them. Ceramics are not. So your ceramic cookware is great. Think about it. My mother used an iron skillet back in the 40s and 50s. There was no Teflon.
Yeah.
My mother had, her couch was covered in plastic. They bought a new couch. I don't know if do you remember that? Maybe your grandmother?
Yes, grandmother's house was famous because there was plastic on the carpet.
We don't want to stain. Today, we don't worry about it because we have stain-resistant fabrics. Oh, that was good. And it is good. But there's a price to pay, and we're paying for it with our fattening and other health effects too. But this book really focused on obesity because people want, if they don't think about their health when they're younger, they think about their looks. When you get older, you don't care so much about your looks, you care about your health. So it's one way or the other, obesity becomes a real menace, particularly from a health standpoint. But yes, these are the things that you can identify. You're dry cleaning. That's perchloroethylene. That's what they use. They used to use carbon tetrachloride. That's a carcinogen. They got away with that. That all went into the soil, by the way. Still there. It's a forever chemical. It doesn't break down into anything. It's kind of like some of the chemicals we used for insecticides and herbicides and everything that we spray on the crops. Many of them are obesogens. And so you sit back and you say, okay, I'm going to identify and I'm going to prevent, but you use your dry cleaning, for example, I was talking about. It's in a plastic wrap, right? If you hang it in your closet, all of those chemicals are being trapped in that plastic wrap because the clothing is off-gassing. You don't smell it, but it's there. It's invisible, but why don't you just take the covering off outside and not hang it up in your closet with the plastic covering on it? There's a simple thing you could be doing to decrease your exposures to these kinds of toxic products. So the book goes through a whole bunch of different things you can do for prevention. There are makeups that don't have parabens. Many of them. There are cleaning agents that they call them green, but what they are is chemical free. And that's, as best as you can, you need to do that kind of replacement activity. That's what people need to do. And diet. You see, the fact is, I believe that I don't care how my patients lose weight. I don't care. You want to go on a paleo diet, go on a paleo diet. You want to go on calorie, you want to go on Ozempic or Wegovy, go on it. 3 months is your diet period. After that 3 months, you have to go to a sensible diet while you're using the AIPE protocol all along. And I don't sell any products. There's no products that I sell here. It's just there are certain products that are available out there that help block the absorption. There's one or two that can help eliminate the toxins that are in your body. People are hearing more and more about them, but they are available.
This is where I wanted to ask you a question. I wanted to go
Sure.
deeper into that. Without going into the details, my doctor spoke about I think it's almost a charcoal that I can swallow to help eliminate bad stuff. I didn't really, I'll confess, again, I don't need to go into the details, but the thing that I heard was basically charcoal.
Yes.
And as I was reading your website, I stumbled onto the name of something that I thought that sounds vaguely familiar. Maybe that's what she was talking
Well, it's
about.
an activated charcoal. You can use
Activated charcoal.
charcoal. You can use certain algae that no, and they're in capsule form. It's not like you have to go out to a pond and eat the algae. But there are certain other adsorbents. They adsorb. They take those chemicals and absorb, so they never get into your body.
They never get outside of your digestive tract,
They never get out of the colon, out of the intestine. That's right. They don't get into your blood.
but they're still able to clean. Help me out here.
They don't clean your body out. What's in the blood is in the blood.
Okay.
The only way out of that is urine or sweat. And
Okay.
sweat has a small amount because sweat has a small fat content. So if there's fat content in sweat, you're getting the toxins that are in your sweat out. That's why infrared saunas are good only because A, they get a little deeper, and B, you can sit in an infrared sauna longer. They only have to go to 80 degrees or 75 or 80 degrees. You don't have to crank up the heat. So you can sit in this infrared sauna for 45 minutes to an hour. No problem.
I never knew that. I'm learning all kinds of stuff here. Okay, so
And the other thing is getting it out of your body. There are a group of chemicals that are being used. They are basically chelating agents. Okay. The problem with
what
general
does that mean? What is chelating? What I've heard of chelation,
chelate is a
my
crab.
doctor does it, but I don't even know what it is.
It's a crab is a chelator. They use the claw. Chelate means claw and remove. Chelators are molecules or compounds that will bind toxic, primarily metals like mercury, lead, cadmium, arsenic. Are they obesogens? Some of them are. Tin. You can bind them and eliminate them from the body. The problem with most chelating agents is they're indiscriminate. So they'll take out calcium. Oh, wait a second, I need calcium. They'll take out, sodium. I need sodium. You need potassium. I mean, you need those things in your body. You don't want to. And then there are some natural chelators which remarkably have no affinity for the things that we want to hold on to. So when you do chelating, when a doctor does chelating in his office, he has to replenish your calcium and replenish your magnesium and give you back the things, or you're going to be in trouble. There are certain chelators. One class is called zeolites. Zeolites.
That was the word. That's the word I saw on your website.
Zeolites. What are zeolites? They are chelating chemicals that are natural in occurrence. They come from volcanic ash. There are many zeolites. For example, asbestos is one of the zeolites. Zeolite. There's another one, not asbestos, but another zeolite, which will trap the smaller molecules. Just so happens mercury, lead, antimony, tin, cadmium, arsenic, they're really tiny. They fill in these little cages, like a honeycomb, like a beehive honeycomb. And they fill up these cavities, and they're water soluble. What's nice about them is that they occur in plates, and so they trap between the plates the organic molecules, things like organophosphates, things like formaldehyde, things that get into our body and would otherwise be in our fat cells, but now they're made soluble without having to go through the liver and be broken down. So now, most zeolites do not get into the bloodstream. Most zeolites that are available commercially do not. There are a couple, we talk about it in the book, that have been micronized and are solubilized and cleaned up to the extent that when you take it by mouth, about 50% of the dose actually is absorbed into your blood.
Huh.
And then comes out in the urine, but it comes out with a whole bunch of toxic stuff. So I was actually involved in a couple of research studies with doing that. We looked at coal miners, we looked at a whole bunch of other people, and you can just eliminate the stuff from the body. What I would love to see is more and more attention to which is better, cleaning the environment. I don't think we're going to do that. You're not going to get rid of 85,000 chemicals. It's not going to happen. You may get rid of one or two, but gosh almighty, we can't even get rid of, what is it, the bisphenol A in baby bottles in this country. Are you kidding? The chemical industry lobby is huge. I mean, you can't buy bisphenol A bottles, baby bottles and nipples and stuff like that in the UK. In Canada, it's outlawed, but not in the United States. No. And we don't stand a chance really eliminating all of these chemicals, but what if we spent our money cleaning up our own inside environment? That would be good. We'd have fewer epigenetic changes. We'd give birth to children with fewer epigenetic changes. And generation to generation, obesity will at least stop getting worse and probably get better. And that's the thrust of the book. For people on an everyday basis, oh, okay, that's all really nice for the future, doc, but what about me? You know what? You want to go on a diet and not gain the weight back? Start putting this plan in effect. Understand why you're doing it. Read the book. It's a simple read. It's not really complex. Some of it's humorous. Some of it's enjoyable. Some of it's eye-opening. To find out that the food industry, is heavily involved with, for example, the school lunch program. Did you know that?
Yeah.
Oh,
yeah. Unfortunately.
Oh, yeah. They're on the board of every one of these federal organizations. They have representatives there from the diet companies and from the food industry. Ketchup is a vegetable. Remember that?
Oh, yeah.
Yeah.
So we have, a lot of this audience is focused on changing the food that they eat as a primary treatment modality for, obesity, among other things, right? We talk about heart disease, diabetes, all of these things, but, and they focus on the food that we eat, right? And we focus on eating, non-processed food. We tend to favor more of a lower carbohydrate approach. A lot of my audience, goes very low carb, carnivore type approaches. And, and they have success. And I think there's above average result when it comes to maintaining the weight loss. And one of the things that occurs to me as we've been having this discussion is I think a lot of people in this community end up doing what you're talking about, even if they may not really recognize it, right?
I think you're right.
They eliminate the processed food. They do start paying attention to things like, the soap that they're using and the makeup and, and they just start paying attention to having a cleaner environment around them. And it sounds like, a lot of what you're talking about is really just that, right? It's not only about cleaning up the food that you're putting in your mouth, it's about cleaning up the environment around you.
Absolutely.
And
I think that what was comforting to these people that you're talking about is that they didn't understand that there was science behind all of this. It just made common sense. Why am I eating these chemicals? Why am I doing that? When I was a kid, my parents and my mother shopped every day for fresh vegetables. We never had a can of vegetables of anything. But at any rate, I think that population that's listening and watching, your people are good in that they're doing this kind of stuff because they're concerned about their health. But I think we, as stewards of the information, have to recognize that it's not fair that in certain populations, we all know where they are, they're in the inner cities and so on and so forth, they don't have access to those kinds of foods. They don't have the access to the fresh vegetables. They don't have the options. They buy packaged foods. And unless we make a change there and get that population demanding more and more, we're still going to be stuck with high obesity rates. And I won't even go into, because we don't have time to go into what it means in industry, in corporations, and how many days are lost from work because of obesity-related diseases. Disease and diabetes and so on and so forth. The cost of health insurance goes up because that population's driving the cost. That's why it's going up. Yes, I think that for those listeners that have been employing all of these things, God bless you. And I think that the book will show you that there may be even better or additional ways of approaching this. But we need to spread the message because it needs to be widely disseminated. And I appreciate you guys having me on.
Yeah, definitely. And I do think that exactly for what you said, learning why it's been beneficial that they've done this will be fascinating for people to read. Let them know, where they can find the book, where they can connect with the rest of your work.
So my work is on my website. It's very easy, drlonky.com, drlonky.com. They can buy the book there. They can buy it at Amazon. They can buy it at Barnes and Noble. Some local bookstores have it, but those are the best, barnesandnoble.com and amazon.com and my website. The benefit of the website is we put a newsletter up there pretty regularly. We put our blogs up there. And there is another book that I am working on right now with a co-author called Invisible Killers. And it's about all of these toxic events, all of these toxic chemicals, and what they're doing to us from total health perspective. And they can get more information about that from the website.
Great. Yeah, we'll definitely look forward to the second book. But this book, again, it's called Outsmarting Obesity. And encourage everyone, go to drlonky.com and check it out. I think you'll find it quite interesting. And thank you for coming on. This is a different perspective of obesity that we haven't really explored before. And I think it's a fascinating, aspect of this epidemic, this pandemic that we're battling against.
I agree with you. Thank you so much for having me. It's a pleasure.
Really good stuff.
Okay.
Really good stuff.
Have a
All
great
right.
day.
Well, folks, this has been Stay Off My Operating Table with Dr. Philip Obedia. Our guest has been Dr. Stewart Lonky. All that contact information will be available in the show notes. Just go there, click on it. You can get to his website and read all and get the book. I personally am fascinated with this stuff about the fat cells and the oxygen and the zeolites. So I'm gonna be doing a little bit of reading. Thanks for joining us, and we'll talk to y'all next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovedia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.